We'll move on to the next speaker, Dr. Arjun Kalyanpur, who is the CEO of Teleradiology Solutions, which is a healthcare company headquartered in Bangalore that reports radiology scans for over 100 hospitals in the US, Singapore, India, Europe, and Africa. Teleradiology Solutions was ranked the #1 teleradiology company in the US for 2011 and awarded the title of Best in Class. It is the first organization outside Singapore to be accredited by the Ministry of Health, Singapore, and was showcased to President Obama on his visit to India in 2010. The organization also has a software company, Telerad Tech, a non-profit division, the Telerad Foundation, and a teaching website. Dr. Kalyanpur is a visiting faculty in the Department of Diagnostics Radiology at Yale University, and is an active member of the Radiologic Society of North America and the Indian Radiology and Imaging Association, and is a reviewer for the Journal of Emergency Radiology. Welcome, Dr. Kalyanpur.
Thank you very much for that kind introduction. It's a pleasure to be here. I'd like to thank HOSMAC for inviting me. We've heard some interesting stories this morning about the growth opportunity in healthcare in India. All of them are true. But there is one challenge to all this growth, which I'm going to be discussing in the course of this presentation. And I'm also going to be showing you how technology innovation can be used to change that challenge into an opportunity. But before that, I'd just like to take you through a quick visit about the evolution of radiology over the last decade. If we sum it up in 3 words, those are speed, resolution, and fusion. So if we look at the CT scanner on the top left, what has happened over the last decade is that it has gone from a single slice to 4 to 16 to 64 and now to 256 slices, to the point that we've even stopped counting slices. What this means is that we have significant improvement in both speed and resolution, and we are able to image structures such as the coronary arteries and the small vessels of the brain, which we couldn't do 10 or 15 years ago. On the other side of the spectrum, we have the ability now to combine technologies such as to both digital. So we have an MRI radiography and digital radiography. Fusion of anatomic, the X-ray is now simple digital file imaging. Can be transmitted anywhere. Exceptional clarity, and both applies to mammography. In the field of ultrasound, we have increasing portability. If you look at the lower end, G-Scan developed by GE, the low lens which you can carry in your pocket, and it can be used to deliver exceptionally high resolution images, which can also be transmitted to different locations. From the consumer perspective, we have issues of lifestyle, diet, obesity, sedentary existence, and smoking, all of which have combined to give us a rise in the big 3, which is heart disease, stroke, and cancer. We all know about these issues. But from an imaging perspective, what this means is that we have people living longer with chronic ailments which require repeated imaging. So the number of scans over a person's lifetime is significantly going up. If we look at this graph from the United States, this is from the Center for Medicare and Medicaid Systems, you can see that the utilization of imaging has gone up 4-fold over a decade, which is a very, very remarkable trend. And from the industry perspective, the figures are similar. So it's healthy growth. We have MRI showing a growth rate of 15%, CT show mobile imaging. If you could get our roads fixed, I think this would be a very, very significant opportunity. In terms of the value proposition, we have a large captive population, which is a potential market. We have a government that's today rolling out public-private partnership models, so there's an opportunity there. And in terms of reducing costs, the capex of setting up a diagnostic center today is significantly lower than it used to be because of a thriving refurbished imaging industry, segment, which just as you can buy a used Mercedes or a BMW, you can today buy a used MRI or CT scanner at a fraction of the cost, and it comes with support and everything. So with all the good news, what's the catch? This is the catch. We have a crisis in terms of a global radiologist shortage. A country like the United States has 1 radiologist for every 10,000 members of the population, and they consider themselves to have a problem. In our neighboring countries, developed countries such as Singapore and Japan, it's slightly worse, but still not too bad. But when you look at India, we have 1 radiologist for 100,000. That's a pretty abysmal ratio. and some of our less developed neighbors have it even worse. So this is a serious crisis, and as we can see, it affects both developed and developing regions. You will see headlines in BBC News that tell you the same sad story as the headlines from dawn in our neighbor Pakistan. So what is the solution? Unfortunately, cloning has not reached the stage today where we can use it to clone radiologists. Otherwise, this would be a very attractive proposition. And I'm longing fervently for the day when this becomes an established process. But till such time, we have to come up with an interim solution, and one presents itself in the form of teleradiology. Now, in its basic form, it's a very simple concept. You take an image from the location where it is acquired and transmit it to another location for the purpose of diagnosis. That is it in a nutshell. But the significance of it lies in the effects that it has, how it can transform the entire diagnostic imaging industry, and what is the value proposition it provides. Number one is access. It allows us to deliver a diagnosis where there is no radiologist and when there is no radiologist. And I'll talk about this in a moment. Productivity. Before I started teleradiology, I worked at the Satyasai Hospital in Bangalore, and I would report probably about 10 scans or 15 scans a day, and that was on a busy day. If we have every radiologist in the country reporting 10 or 15 scans in a day, we're out of business. The healthcare industry could not possibly survive. So it's a key challenge for us in the radiology sector to increase radiologist productivity and at the same time to preserve accuracy. So there is a balance that has to be achieved here. Affordability is another issue. The healthcare system is rapidly spiraling out of control in terms of costs. And as I will show you in a moment, teleradiology impacts on all of these parameters. Let's talk about the time advantage first. One of the things that we do in our organization is report scans from countries on the other side of the world. And the advantage that provides is that the patient comes into the hospital at 3 in the morning. The radiologist is not available on site. If you had to wake up the radiologist at home and bring them in, it would take half an hour, an hour, 2 hours. Within 15 minutes, we can deliver a report to the other side of the world in situations such as acute stroke, pulmonary embolism, aortic dissection, life-threatening emergencies. An instant diagnosis to any part of the world is possible using teleradiology. So there are two benefits to this. One is, of course, the instant diagnosis, which impacts on patient care and patient outcome. The second thing is radiologist productivity. You have the same radiologist working during the day instead of during the night, which means that they are able to do that many more hours of work without compromising on quality. Also, in the teleradiology environment, you have an economy of scale. You have one radiologist reporting for multiple centers, and so your cost comes down proportionately. Singapore has benefited significantly from this process. We have been reporting for Singapore for about 8 years now, and the Prime Minister of Singapore, Mr. Lee Kuan Yew, made a speech in Parliament where he mentioned that this was something that had significantly benefited them. It brought the turnaround time from 3 days. It took 3 days for clinics in Singapore to get a radiology report, and we were able to bring that down to 1 hour using teleradiology. So, in our organization, to give you an example, we are serving hospitals in all of these countries, and our radiologists, are in a bunch of locations around the world. So we have a global delivery model. Your radiologist can be anywhere. By spreading them across the globe, they can deliver services 24/7 without anyone having to stay awake at night. This is something that has been validated repeatedly in the literature. We've had the privilege of being contributors to some of these articles. But the one at the bottom right, I think, was the most interesting one. It was an editorial in the New England Journal of Medicine a few years ago, which talked about international teleradiology and the benefits it delivered. So it's worth a read. It for once gave a positive slant to Indian medicine. Access. So when I was a medical student at the All India Institute of Medical Sciences, we used to get patients in the OPD queue who were from Kidwainagar across the street, and behind them in the same queue were patients from places like Bihar and Orissa and Madhya Pradesh who had come for hours on the train to get here. Today, I think it's a criminal offense for a patient to have to travel anywhere simply for the purpose of diagnosis. Diagnosis needs to be decentralized, especially when we have a situation where there are so few radiologists. I'm going to try and play this video. I'm not sure if it's going to work. So this is a concept called telesonography. You have an ultrasound scan being done in a rural center, captured on a video phone, and the same equipment is available at the remote reporting center. The radiologist can view the image in real time and make a diagnosis without the patient having to be transported. This is particularly helpful in settings such as ICU or in pediatric centers particularly. Here's an example, a patient in a hospital in Arunachal Pradesh. This hospital is fortunate to have both a CT and an MRI scan granted to them by the government. It's a mission hospital. But they are only able to get a radiologist twice a week to come and report scans. So this patient who is admitted with acute appendicitis, the scan is positive. You can see a thickened appendix on it. The scan would have sat for 3 days without a report. The patient would probably have gotten sicker and sicker. The appendix could potentially have perforated and ruptured. But by transmitting the image to our center, the report is done within the hour and the patient can be operated. So rapid access and rapid turnaround are both tremendous value adds. And when you're talking about scaling the healthcare industry, this is something that is very, very critical, because without providing such immediate reporting services, it's very difficult to set up new hospitals or new imaging centers. We did a study last year where we reviewed our own experience with teleradiology within the country, and we could see that there was a steady growth in utilization of teleradiology from over a 5-year period. Diagnostic centers tended to use our services more than hospitals, which was interesting because it seems like both required the services just as much. Across the country, there was pretty uniform utilization if you look at all the different states. The Northeast tended to use our services more, probably because of a more significant shortage of radiologists in that region. And all modalities tended to be used. Teleradiology was used for all modalities. In terms of drivers, I think the technology revolution has been key for the development of teleradiology. It's allowed us to scale. We have penetration of connectivity into all remote places now, especially with Wi-Fi, so on. It's become much easier to deploy teleradiology services. A key driver is economic. Not sure if the print on this graph is visible to all of you, but this is a graph showing physician compensation. This is in the United States, but it's not very different from India. And the radiologists are in the third from the left. So they're at the highest end of the reimbursement spectrum. Now, when I put on my radiologist hat, I'm very happy to look at this graph, obviously, but when I look at it from the perspective of healthcare economics, it's a very, very difficult situation, because unless you can increase, as I said, the productivity of that radiologist, or in some way bring down the cost of the whole radiology system, this is going to be a problem. And of course, articles like this, which increase awareness, or the New England Journal article, are tremendously important in spreading the word. I think Healthcare Executive has done a tremendous job in this regard as well, so my compliments to you. Let's look at the technology for just a moment. The key feature in teleradiology is the cloud, and we hear a lot about the cloud in various meetings and conferences. I think in teleradiology it's particularly important because it allows us to decentralize our infrastructure, which immediately gives us redundancy. We don't need backup servers within our office. It gives us access from anywhere, seamless access, and it gives us a model, a financial model where we can pay as we use. So we don't have to invest in $1 million PACS equipment. We can simply utilize a remote service as and when we need it, and at least as much as we need it. A radiologist, in a very crude, to put it very crudely, is like a carpenter. He is only as effective as the tools he uses. And workflow is the essence of radiology today in the teleradiology environment. If we are unable to have the radiologist time utilized effectively, by bringing the images to the radiologist and providing them with a workflow environment where they can read efficiently, their time is wasted, and radiologist time, as we've seen, is extremely expensive. So workflows such as this can really help in addressing the radiologist shortage. Mobile is another very interesting phenomenon. I think today the interesting thing is that you carry a PACS workstation in your pocket. You have all the capabilities of a radiology reading workstation on the phone. Today there are servers such as this one. This is a mobile version of our teleradiology server, which is available on the iPhone, the iPad, and Android systems. And it can be used to detect subdural hematomas, acute strokes, pulmonary emboli. So this can be actually used by clinicians as well. It's not just for radiologists. A stroke neurologist can review the CT on this patient using this system. And so this really improves access and makes it immediate. Here's a disruptive innovation. This is a project we recently completed where we're using the smartphone not just as a viewer but also as an acquisition device. We've done a pilot where we have digitized X-rays using the smartphone in small primary healthcare centers where they have no, community healthcare centers where they have no digital equipment, they have the old analog systems. You use the smartphone to capture the image, upload it using an application which we've developed to our server system. It's reviewed by the radiologist and the report is generated and transmitted back to the phone of the referring clinician or the referring CHC. Scaling of radiology can only happen in the long term by training more radiologists. I think teleradiology is a very valuable source of teaching information, and we in our organization, as was kindly mentioned during the introduction, are using technology for all it's worth to spread education. We have a teaching website, we have an online e-lecture program, and we do e-teaching on a regular basis with the idea of creating more radiologists and better radiologists by continuing education. When you talk about scale, there is a balance that has to be maintained between scale and growth and on the one hand and quality on the other hand. So I think it's worth spending a second on this concept because in radiology, the report quality I think is paramount. You're only as good as your last mistake. So the certification, the training of the radiologist is important. Organizational certifications such as Joint Commission or class evaluation, and we were fortunate to be rated best in class, are important. I think the NABH can play a growing role in the future in our country in terms of accrediting freestanding and teleradiology centers. And of course, from this technical standpoint, we have issues such as HIPAA and FP8 to deal with. There's not much that's written about cost in teleradiology. These are just a couple of papers that I was able to find in the literature. The one on the left is from Germany, shows a reduction in cost per scan after teleradiology was implemented. And the one on the right is from Japan, and it's a very complicated business model that they've developed, but they have basically shown that the willingness to pay in the end is a parameter that they've used to show that cost was significantly brought down once teleradiology was deployed. So there are studies out there which are able to scientifically prove that teleradiology brings down the cost of imaging. So that's the story as it is. If I'm to look into the future and peep into my crystal ball, what do I see happening? One technology trend that's very exciting is CAD, or computer-aided diagnosis. It's got certain specific applications today where it's being used in terms of lung cancer detection, breast cancer detection, virtual colonoscopy for polyps. There are a few isolated indications where it plays a valuable role. As it grows and evolves and the technology improves, I think this can be a tremendous support system for radiologists, further increasing their productivity, especially in the teleradiology environment. Subspecialization, I think, is a necessity within teleradiology. To be able to bring the scans to the most qualified subspecialist is itself a very valuable tool, because let's face it, if you have a complex neuro scan, you want a neuroradiologist reviewing it. And finally, I think in India we have 5,000 CHCs and about 25,000 PHCs. And I think the goal of universal access is to have some basic form of imaging at all of these centers. There are many of these centers in India today where the radiology equipment is lying idle because there is no radiologist to report the images. The clinicians are reluctant to order the studies because they won't get a report, they don't know what to do with the scan. So I think implementing teleradiology can really help in bringing quality diagnosis to all of these locations. And that's my final point. Thank you very much.
We'll take one question.
Yeah, I'm Aman Behel from Sonosite. For telesonography, how do you ensure, what the biggest challenges in terms of compliances under the PCP and DT Act? How do you ensure that? Because in many of the centers you said, where you are linked with, don't have qualified radiologists,
right?
And the technicians are doing it, the sonography. Now, I don't know whether under the PCP and DT Act, that is allowed. And what are the precautions that you take at your end?
Unfortunately, that you hit the nail on the head. I think that's the biggest obstacle to the growth of telesonography in India is the pernicious practice of female feticide. Because of that, we have PNDT Act. As a result, the technology which has significant potential is not being realized. So, in fact, the V-scan that I showed you, which has been developed by GE, unfortunately hasn't gone anywhere because the restrictions about the usage of ultrasound are so stringent. But I showed it as a concept because I think there is, and interestingly, in other parts of the world, it is being used eminently. In the United States, there is no, exactly. So I think it's the way of the future. I think if we can, I think the pendulum has swung to the other extreme in terms of the PCP and DT Act. We've gone from a situation where there was rampant abuse to now I think we have overreacted a little bit. I think we need to find some balance. And I think if that balance is found, then I think telesonography can play a tremendous role, because if you can have a technician doing the scan and a radiologist in a different location reporting it, I think there's a tremendous potential for achieving high quality ultrasound.
Have you taken up the matter with the government?
There have been committees, the IRI has had discussions with the government. As of now, I don't see any immediate resolution of the situation, but it's in discussion.
Right. Can I request Mr. Arun Datta to please give the moment to Dr. Kalyanpur? Mr. Datta has experience over 3 decades as ex-HR director of Medanta, Escorts, as well as Bombay Hospital.